of AIMS Delhi, and after retirement, who shifted to KIMS. We had a wonderful teacher, a superb human being, and a researcher, a clinician. I mean, the words are less to describe his greatness. We lost him, and we all pay condolences to the bereaved soul and hope that the family of Professor Dash bears the strength to bear this irreparable loss. Second is again a tragedy which has happened today related to the medical college. The aircraft which just took off from Ahmedabad in the afternoon today, I believe within minutes of taking off, it struck something, it crashed. We don't have the details that how many have died. It was heading towards London with almost 240 passengers. But I think the way it has crashed in Vijay Medical College, I think there is a loss to medical students. We will come to know the details later. I think before starting, I pay condolences to all who have lost their life. And as I said initially, to Professor Dash. After paying the homage, let's now move to our first episode, which is on ANCA-Vasculitis. We have got we have got a lot of great people today. Uh, we have got Dr. Raja Ramchandran, who is the additional professor of nephrology at PGI Chandigarh, who is the examiner today. We have got Professor Aman Sharma, again a renowned man in the field of rheumatology, a Dronachari in the field of rheumatology, who has been editor-in-chief of Indian Journal of Rheumatology, who is the president-elect, I believe, or president of Rheumatology Association of India. I mean, he is a very keen researcher, and I believe he has invented few new diseases in rheumatology. I think he is the discussant for the topic. And again, a third master, an expert, and very senior and doyen in the field of nephrology, Professor Kasi Visweswaran, who he has been our teacher for all of us. And he is presently consultant in Anantapuri Hospital, who was previously principal, vice principal, and professor and head at Trivandrum Medical College. So these are all the discussant and experts today. I'll request Professor Vijay Kher, again another doyen in the field of nephrology, who is the co-convener, to please introduce the topic and proceed, sir.
Thank you. Thank you, General Verma. I think the topic is ANCA-Vasculitis, and I think we have such an exceptional persons today. Dr. Aman Verma, I must add, in addition to what Dr. General Verma has said, is Aman Sharma is has the largest collection of ANCA-Vasculitis in him, and he runs a department to which I have been personally very close to, and with Dr. Deodar, the initial person who set up the department, and then Dr. Bamri, both being very close friends. And it's very good that Dr. Aman Sharma, with all his experience and everything, I've heard him many times, and he's always been something that you learn new from. So I will feel that all the people who will attend, and I'm sure they will spread the word, what things they are going to listen today, and they will definitely benefit from it. And I'm sure all of us will benefit from. Dr. Kasi, another a close friend. I think we worked together in PGI at the same period of time, and is always been in close touch with him. He has always maintained his academic interests all along. Published many books, and it would be very, very nice to have him as a guru, or as an final. How does the current recommendations, how would he translate it to the patient in the day-to-day clinical practice and all that? So he will provide those wisdom words at the end of the presentation. And I think with this, I would go straight rather than spending any more time on this. And I would request Dr. Srinath Reddy from again, who is third year senior resident in the Department of Nephrology at PGI Chandigarh. So, Dr. Srinath,
Yes, sir.
you
Good
can go
evening.
ahead. Rajaji, have I your permission to start?
Yeah, perfect, sir. Perfect. So, it'll be like, an approach to a case of an RPRF.
Sure,
And
sure.
then, Dr. Aman will talk about the treatment. So, we will not be discussing anything about the treatment in the
Okay.
45
Yeah,
minutes.
yeah, it's good to.
Good evening, everyone. Today I am going to present a case of my patient, 25-year-old male, resident of Chandigarh, graduated, shopkeeper owner, came with chief complaints of left ear pain 2.5 months back, left eye redness 2.5 months back, associated with joint pain since last 1 month, fever since 2 weeks, shortness of breath since last 3 to 4 days, and decreased urine output since last 3 days. Coming to the background history, my patient was apparently all right till March 2025 when he started complaining of left ear pain, which was acute in onset, gradually progressive, dull aching pain, which was referring to the jaw. It was associated with left ear discharge, associated with hearing loss, and there was no vertigo. At the same time, there was left eye redness, which was acute, gradually progressive, associated with pain, photophobia, and blurring of vision. Uh, there was itching, but no lacrimation. Further, for which patient went to GMCH 32 hospital, for which patient received antibiotics, oral antibiotics for ear discharge for 7 days, along with some ear drops. In view of left eye redness, patient went to ophthalmology OPD in GMCH 32, where in view of ophthalmological finding, patient was advised to do Montu, which came to be positive, which was around 18 mm. During same period, patient remembers that his blood pressure was within normal limit and hemoglobin was 10 with normal creatinine value. Later, for this Montu positive with ophthalmological features, patients was started on anti-tuberculosis treatment. After that, patient started complaining of joint pain, which was large joint involving knee joint, shoulder joint, which was asymmetrical, migratory in nature, not associated with swelling, not associated with any early morning stiffness. Patient used to remain in the bed, and there is a limitation of the activities, which was non-erosive and 2 weeks back, which was low grade, around 100 to 101 degree Fahrenheit, intermittent, not associated with rash. It was associated with loss of appetite. Loss of weight was there around 3 to 4 kgs in the last 2 months. When he presented to PGI 1 week prior, there was cough, which was acute in onset, gradual, not associated with expectoration, but there was hemoptysis around 20 to 30 ml per bots was there. And patient was having shortness of breath since last 3 to 4 days, which was acute, gradually progressing. MMRC grade 2 progressed to grade 4. It was associated with orthopnea and associated with right-sided chest pain. Further, since last 3 days, there was decrease in urine output, which was associated with pedal not associated with frothuria or hematuria. There was no complaints of lower urinary tract. There was no history of rash or similar complaints in the past. No history of alopecia, dry mouth. No history of any hoarseness, recurrent sinonasal infection, epistaxis. No history of purpura, Raynaud's phenomenon, or no history of any headache, visual loss. There was no history of any use of recreational medications or no history of any tingling sensation or numbness. For above complaints, like cough, shortness of breath, and decreased urine output, patient came to PGI. In PGI, at admission, patient's creatinine was 5.8 and patient's saturation was around 78% and room air. So patient was kept on NRBM, and in view of advanced azotemia and possibility of fluid overload, patient was started on hemodialysis. Patient first received hemodialysis for 2 hours and followed by ISOF for around 2 hours. Later, HRCT was done, and in view of low hemoglobin and HRCT finding suggestive of possibility of diffuse alveolar hemorrhage, patient started on plasma exchange with albumin and FFPs with injection MPS pulse 1 gram, which patient received for 3 days.
I am Kashi here. At this stage, just when the time when the patient came into PGI with renal failure, at that point of time, can you consider any other possibility?
History of this and history more likely suggestive of its multi-system involvement is there. So likely possibility of, sir, because of decreased urine output, which was around 3 to 4 days, associated with periodema and previous documented normal creatinine, so possibility of rapidly progressive renal failure is more, sir.
Yeah, rapidly progressive renal failure. That is a diagnosis, but can you think of any other cause for rapidly progressive renal failure?
Sir, with this background history, as of now, I am considering RPGN one of the possibility, and second
RPGN,
possibility,
yes.
RPGN secondary to vasculitis, sir. And second possibility will be, sir, he was on ATT. RPRF because of acute tubular intestinal nephritis because of rifampicin can be there, could be there.
Okay. Okay, that is a recent development of renal failure.
Yes,
See,
sir.
you gave a history of something like a uveitis,
Yes, sir.
and following the uveitis, he was started on ATT.
Yes, sir.
Then he started worsening of symptoms.
Yes, sir.
So, would you like to consider
Sir,
immune
iris can be
reconstitution?
possibility.
Would you consider immune reconstitution inflammatory syndrome for the worsening of symptoms and subsequently rifampicin-induced worsening of renal failure? So you can't straight away think of your
RPGN, yes, sir.
ANCA-Vasculitis or anything as a first diagnosis.
Yes,
Because
sir.
we have already given plasma exchange and all. That would not have been the ideal treatment for the. There has been reason for giving plasma exchange, but you must also consider this possibility because tuberculosis is common.
Yes, sir.
And tuberculosis is common, and then this sequence of events can also be explained by tuberculosis. That you have to keep in mind. Just
Yes,
a comment, because when I saw that history.
Yes, sir. Further, because of low hemoglobin and HRCT finding suggest of DH, patient was started on plasma exchange. Patient also received PRBC transfusions. Later, patients started on prednisolone 1 milligram per kg, and at the same time, patients titer were sent, and PR3 ANCA came to be 143 units. MPO ANCA titer was around 3 units, and anti-GBM was negative. After 7 days of 7 days, patient's oxygen requirement decreased, and patient was off O2 after 1 week. Later, patient was on hemodialysis via right IJV tunnel cuff catheter every alternate day.
Okay, I think this is fine. So maybe you have anything more to say with respect to his clinical symptoms, or you want to summarize or anything? Is there any positive finding on examination, or you want to then summarize, or you can, because it's a clinical discussion, so I don't want to go into, those kind of details, treatment, biopsies. We can discuss all those during the follow-ups. Yeah.
Okay, sir. Certain positive finding in examination. There was, sir, old nasal nasal oral ulcer was there, sir, and sir, I mentioned in further slides, sir. There was healed ulcer at the angle of mouth, sir, and as of now, patient is off O2. There is no specific complaints. So other examination is normal, sir.
Can you summarize the case?
Yes, sir. My patient, 25-year-old male, with complaints of ear discharge, left ear discharge, along with hearing loss, with left eye pain, uh, uh, left eye pain, likely possibility of scleritis or uveitis. Patient was started on ATT in view of considering tuberculous uveitis. Later developed joint pain, fever, followed by there was cough associated with hemoptysis, with shortness of breath, and decreased urine output associated with pedal edema. My diagnosis possibility will be, sir, any multi-system involvement, multi-system disease, likely vasculitis, sir.
Hmm. So now that you're completed, see, whenever you make a diagnosis, even if you have a diagnosis written on the face of the patient, you're first supposed to make, is it, what kind of syndrome is this? This is acute kidney injury? Is this nephrotic syndrome? Is it RPRF or CKD? What is this?
Sir, this is rapidly progressive renal failure, sir.
Okay, first it's rapidly progressive renal failure. After that,
After that, sir, by compartment wise, sir, likely rapidly progressing glomerular nephritis, sir. And second possibility of tubular compartment is, sir, ATIN.
see, this is for residents also. See, whenever you make a diagnosis, you first make a syndromic diagnosis. After the syndromic diagnosis, you try to get on the systemic illness. Like, if it's an RPRF, then you make a diagnosis of probably an ANCA-associated vasculitis. If it is AKI, you probably make a diagnosis of drug-associated AKI. CKD, you say CKD-U or analgesic-related kidney disease. Then after that, in CKD, it may not be an issue, but RPRF, nephrotic syndrome, you need to go into the histology. Like, what could be the probable histology? Like, this patient is presented with, you know, uh, dialysis requiring acute kidney injury. So probably this is a crescentic GN. And also you need to say that this is a case of diffuse alveolar hemorrhage. Along with that, what is this kind of a syndrome called?
Sir, good posture syndrome, sir.
A good postural syndrome or a pulmonary renal syndrome, renopulmonary syndrome. So it's a renopulmonary syndrome, rapidly progressive renal failure, likely ANCA-associated vasculitis is the first differential diagnosis. We can have the second differentials, which we could discuss, and that is how. So why do you call this as an RPRF? I could also argue this, there's a history of only 2 or 3 days illness of
Yes, sir.
decrease in urine output. Why not this be an acute kidney injury? I would argue on a flip side that this is an acute kidney injury. Why do you say it's an RPRF?
Uh, Sir, the duration, sir, it is but a patient complaining of sir cough. There is systemic features prior to development of renal failure. One thing, sir, and the duration is around sir 2 weeks, sir. So for AKI, because decrease in output, patient noticed 3 to 4 days prior to coming to the hospital, and there was still pedal edema and documented BP. Patient doesn't remember, sir. So possibly
Okay.
because of duration, sir, and associated multi-system in the background, sir. So I'm keeping possibility of sir RPRF.
Okay. So I would largely agree that, you base your argument not only on the renal issues, but also, on more comprehensively evaluating the non-renal issues also. Like, the patient has got, he came with ear discharge, hearing loss, which you would like to associate with the kidney disease. So that is one thing. So if I say that uh, hmm, extending it, could this be chronic kidney disease? Like, patient has just developed, it's chronic, the urine output has just acutely dropped. There could have been an acute factor. This patient is probably having an chronic kidney disease with probably an acute deterioration at this point of time. So if I ask what are the telltale signs of or telltale symptoms of chronic kidney disease, how will you ask and what are they?
Sir, is there any history of noxuria? Followed by, sir, if there is there was no specific history of sir noxuria, frauduria, patient didn't notice, sir. And we have sir creatinine, which was in the month of April when patient was evaluated for ophthalmological manifestation, which was normal, sir. And there was
Okay.
no, as per, sir,
So,
any features of proximal muscle weakness and features of any bone mineral disease, sir.
yeah. So, well, what are the features of bone mineral disease? Like you
Sir,
told, there are no features. Like patient will not say, I don't have any features of bone mineral disease. So, is bone mineral disease so symptomatic? Like the patient will say that to you, or I agree that it's a very important. Whenever you speak of chronic kidney disease, nocturia and signs and symptoms of CKD MBD is important. So, what are they?
sir, proximal muscle weakness, which is rare, sir, but there can be, sir, heel pain. Some non-specific pains can be there, sir.
Yes. Where are the non-specific pain? So that is my question. So you ask CKD patient, the non-specific pain, where will be the pain?
Uh, sir, sir,
Like,
most
they don't have arthralgia. They don't have arthralgia. So I'm not. How do you suppose if MBD, what or you don't know? Like, you can be clear about that.
uh, sir, generalized body ache, backache, and sir, hip pain.
See, generally, CKD, MBD broadly, symptomatically is divided into, osteosis fibrosa cystica, that is secondary hyperparathyroidism, and osteomalacia. Osteomalacia is generally painful condition.
Yes, sir.
You can have bone pain all over the body. That is one. And another thing is proximal muscle weakness. That's the second thing. These are the two things that are there with osteomalacia.
Yes, sir.
If you speak about the secondary hyperparathyroidism, there's osteosis fibrosa. They are largely asymptomatic. But if they can have pain on the long bones, and probably in the ribs, the end of the long bones, there can be pain. So that is one thing. Otherwise, it's largely asymptomatic. And
Yes.
sometimes in osteomalacia, you can also have muscle pain. So these are the symptoms that you ask here for MBD. Otherwise, you don't have any CKD specific symptoms unless it's you have an advanced injury, like then you have the GI symptoms, then you can have the neurological symptoms. So that's different. But even before, these are the uh, symptoms that a patient with CKD will give. So it's important when you say that pain means what is a kind of pain. So that's important. That's how you describe it.
Yes,
Yeah.
sir.
So you say that it's an RPRF, it's not a CKD or an AK. I think we agree with that part. So coming to the differential diagnosis, what are the differential diagnoses? One you said is ANCA-associated vasculitis.
Yes, sir.
What makes you think so? See, leave aside the ANCA titers, and if you didn't know the investigations, how will you make a diagnosis of ANCA-associated vasculitis?
Sir, external manifestation were there, sir. Like, sir, there was ear discharge associated with, sir, there was redness of eyes, with some constitutional symptoms was were there. There was joint pain, which was migratory, followed by, sir, which there was fever. So external manifestations were there, sir, and
You feel that the extrarenal manifestations are specific for ANCA-associated vasculitis, or there could be associated with other clinical conditions as well, with renal disease, obviously.
sir, other conditions can be possible, sir, but considering his I have that lab values, sir, because of which I was keeping possibility of ANCA vasculitis.
Yeah,
Second,
so you should.
lupus
So
vasculitis, lupus
thumb
related
rule is you should not carry the investigations with you, because in exams you will not have these investigations given to you.
yes, sir.
Yeah. So what are the other differential diagnoses? Suppose I say a case of RPRF with
Yes, sir.
eye involvement and kidney involvement. What would come to your mind?
Sir, lupus can be there, sir. And second, sir, sarcoidosis can be the possibility.
Yes.
Uh, Sir, IgG4 related disease can involve eye and kidney both, sir. But presentation RPRFs are less likely.
RPRF, I'm talking about eye and kidney alone. Like sarcoidosis is generally a systemic disease. You will have symptoms beyond the eye and the kidney. What is another condition which causes eye and the kidney? And it's an RPRF-like presentation. You discussed it about the clinical condition also, uveitis. You said something about the uveitis.
Sir, TINU, sir,
Yeah. So what is TINU?
tubular intestinal nephritis and uveitis, sir.
Yes. So that is another differential diagnosis if you want to specifically speak about the eye and the kidney.
Yes.
So in a patient, here you have a lot of clear history of ear and eye involvement along with kidney involvement. So if
Yes,
I
sir.
ask about head to toe, like what are the symptoms that you will ask for a patient with vasculitis? What are the symptoms I'm asking? And also you can say at the same breath, you can also say about the examination findings.
Uh, Sir, because of chronic inflammation, alopecia can be there, sir. And coming to eye, sir, there can be uveitis, episcleritis. Patient
No,
can
uveitis and episcleritis is not, patient is not going to tell you about uveitis and episcleritis. So you tell me about what is the symptoms
sir, patient can
and the
present
signs.
uh, pain, sir, followed by redness of eyes. The recurrent episodes of redness can be there, sir. Followed by patient can complain of oral ulcers. There can be nasal discharge, recurrent rhinorrhea,
So
recurrent.
let's go slow. So whenever you say, because these are all important things in history taking at least.
Yes, sir.
See, when you say red, so there is red painful and red painless eye. Red painless eye is much more commoner. So painless is episcleritis. And
Episcleritis.
red painful most of the times is episcleritis is generally more of some sort of irritation rather than pain. Whereas scleritis is pain. And whenever you may find blue spots and thinning out, that is there is recurrent, that suggests that there is recurrent episodes of scleritis. So that is a strong pointer towards a vasculitis. So that is one. So other eye manifestations, can you have keratitis?
Yes, sir. Keratitis can.
And
Yes,
how
sir.
will it present with?
Sir, Sir, the blurring of vision is there, sir, followed by
No
hypo.
blurring. It is just presents with dryness most of the time. So this is why I'm telling you, no. So you should know all these signs and symptoms of other disease also. It's not that only kidney, ANCA is positive, give plasma exchange to the patient. So that is not the question. So then, okay, you said about the eyes. What about the ears?
Sir, there can be otitis media bilateral or unilateral with hearing loss can be there, sir.
So why there is otitis media like in the patient with ANCA-Vasculitis? You ask the symptoms, right? Heaviness of the ears or any discharge. Why do you think?
Sir,
So
inflammation
these
of
are all.
will be, sir, followed by secondary infection will lead to, sir, discharge and because, sir, underlying inflammation of the uh,
This is your
the-
speculation, this is your speculation, spontaneously you're trying to think about something. So it's actually, these are granulomatous diseases. These granulomas involve the nose and the throat, and where they result in blocking of the eustachian tube because of these granulomas. Once there is block of these granulomas, that is why you have otitis media in these cases. Rarely you can also have, you can have affection of the inner ears, you can have sensorineural hearing loss, you can have vertigo and other things. But why does this happen? So it's important to know the pathophysiology behind these symptoms. Then only you will ask specific questions. So that is one. With respect to the nose, what are the symptoms?
sir, nasal crusting, epistaxis, saddle nose deformity can be there, sir.
Okay. So, and then this is about the ENT. And in severe cases, there can be severe
So,
granulomas. Like it's a granulomatous disease, right? So when there is the granuloma is severe, what can happen? It can cause
so
palate,
palate
palate
perforation.
perforation.
Yes, sir.
Yeah, it can perforation of the palate can be there. Then, what are the other ENT manifestations? Quickly, we'll go quickly.
Sir, oral ulcers can be there. There can be
Oral, oral ulcers, yes, it can be there. Not that it's common. It's more common with lupus than ANCA-Vasculitis. But other things,
so stridor
any
can
other ENT manifestation, which
the
is
stridor.
common? It's because subglottic stenosis, because recurrent episodes of, this granulomas and healing, and they can be subglottic stenosis. Subglottic stenosis can present with cough in the mildest form, change in voice and other things. And the severest form, obviously, it can cause stridor, respiratory difficulty, and other things. So that part is one. Any other respiratory tract manifestations?
So lower respiratory tract manifestation like cavitation followed by diffuse alveolar hemorrhage can be there, sir.
Okay, cavitation, diffuse alveolar. Can you just have an ILD-like pattern?
Yes, sir. It can be possible, sir.
And an ILD-like pattern is more commoner with which kind of vasculitis?
Sir, pulmonary.
It's more common with, MPA than with the GPA. GPA is more of cavities and the diffuse alveolar, though, can be part of both the disease. Capillarities can be with both. Then coming to the next GI manifestations.
Uh, Sir, there can be hematochezia. There can be abdominal pain can be there, sir.
So GI
And
manifestation, if I say vasculitis, what comes to your mind?
sir, postprandial pain can be there, sir.
No,
Followed
no,
by
no.
the
Which kind of vasculitis comes to your mind if you say about GI
sir,
manifestations?
IgA vasculitis.
Yeah, that's good. So IgA vasculitis, GI involvement is more profound in IgA vasculitis as compared to ANCA vasculitis. Although ANCA vasculitis can have GI manifestation, we ourselves have reported on this, but it's classical of IgA or PORPOS, previously known as enoxaparin purpura. What is the triad of that?
Uh, Sir, there is abdominal pain, joint pain, followed by renal
Yes.
failure.
No, no, renal failure is not a part of that. Renal failure can be there.
Dash.
Yeah. Yes, so it's palpable purpura,
Yes.
then pain abdomen, and then the third is arthritis. So these are the three things that are there with that. So that's with the GI part. Then skin rashes, can it be a feature of vasculitis? If so, which kind of vasculitis? Or which all vasculitis can cause skin rashes?
Yes, sir. Like, sir, IgA vasculitis, lupus can cause SLE-related vasculitis can cause leukocytic vasculitis, and this ANCA vasculitis also cause skin rash.
Okay. And so with this, this is vasculitis, do you have any other differential diagnosis? Could it be you said that this patient has could another differential diagnosis could be, you know, drug-induced interstitial nephritis. You said the patient was on rifampicin and
Yes, sir.
drug-induced interstitial nephritis. How does rifampicin cause interstitial nephritis? I'm not talking about the etiology. I'm talking about the how does it present with?
Uh, Sir, it can present with non-oliguric AKI. It can also present with, sir, a typical features like, sir, hematuria, and there can be, sir, hypertension, which will be seen in, sir, RC, rifampicin induced ATN, sir.
So, what all you said, you started with non-oliguric AKI. So generally, it's an oliguric AKI. Interstitial nephritis classically does not have a decrease in urine output. But
Yes, sir.
patients with rifampicin-induced acute kidney injury, they present with DPGN-like presentation. What is a DPGN-like presentation? Patient will have acute nephritic syndrome, like, he will have hypertension. Urine will show a lot of RBCs. There will be a decrease in urine output. So that is how a rifampicin-induced acute interstitial nephritis presents with. Is it a common feature with ATT, or is it common with some other kind of regimens?
Mm.
In ATT, do you give daily or you give intermittent rifampicin?
Sir, daily, sir.
Daily. And rifampicin-induced interstitial nephritis is seen with which kind of regimen?
Sir, intermittent, sir, because
Yes,
antibodies
it is
are
seen with intermittent, more commoner with, not that it cannot happen with a daily regimen, it's more common with intermittent kind of therapy. So that is another differential diagnosis.
yes, sir.
So, but yes, less, because your patient did not have very high blood pressure to begin with or at the time of presentation. And what is the other thing that would remain unexplained is hemoptysis, unless you attribute it to fluid overload being the cause of hemoptysis. So these are the two differential. Any other differential that comes to your mind? As sir said, immune reconstitution syndrome. Like, is it how common is it, and how do you make a diagnosis of it?
Sir, after starting it, sir, within 1 week, sir, there will be exacerbation of the symptoms, sir. But this patient's ATT was started at the end of, sir, in mid-April, sir. So duration is more than near about 1 month, sir. And
So it all depend upon like the kind of immunosuppressed the patient is. Like, if he's profoundly immunosuppressed, it'll take a little more time, and if he's okay, then it will happen earlier. So it can happen anywhere between 7 days to 1 month. It can happen. There can be exaggeration of all these symptoms, like, the cough can get worsened, the eye problems can get worsened. There can be fever. Most of the times its common presentation is fever is the most common presentation. You will find that the patient has slightly responded, and then again the fever going up. Then you give steroids, the disease, the fever melts away. So that's how immune reconstitution. It's an important thing. There are uveitis can be a feature of immune reconstitution syndrome. So that's how the differential diagnosis at this point. So you don't have to think about anything like any other interstitial nephritis. What are the causes of RPRF? Like, if I ask you what are the causes of RPRF? We have
uh,
mainly discussed about RPGN. So
yes, sir.
what are the causes of RPRF?
So first RPGN, second, sir, tubular compartment, which is acute tubular interstitial nephritis. Third, sir, vascular compartment, which can be, sir, small vessel thrombotic microangiopathy can be there, sir, in RPRF. And sir, not in this patient, but myeloma cast nephropathy can present as RPRF,
Yes.
followed by, sir,
Yes.
obstructive uropathy can also present as rapidly progressive renal failure, sir.
Yes. I think you have enumerated all the causes of RPRF. So, if you have to approach this case, how will you approach this case? Like, how will you manage this case? Manage means what would be your next steps?
Sir, first, sir, I would like to look for, sir, urine routine, sir, urine dipstick,
Hmm?
to look for any RBCs or any protein, followed by, sir, routine
So
investigation like,
urine dipstick, do you look for albumin, globulin, or proteins, or what do you look at?
sir, depending on the dipsticks, sir, mostly, sir, protein we will look for, sir.
No, no. Depending on the dipstick means what? Most of the dipstick that is available with us looks for albumin only. You
Uh,
don't look for protein. Huh. These are simple things MD fellows will know. Okay, then
Sir, then routine investigation like sir CBC and renal function test, sir. In
okay.
CBC, you look for sir hemoglobin
You
and
said RBCs. Is RBCs? You said you're not moved on from the urine examination. Please stay there.
yes, sir.
So you said albumin. So albumin can be positive. That is fine, acceptable. RBCs. Is it feature of only an RPGN, or it can be there in interstitial nephritis, or it can be there in ATN? Like, how is it?
Sir, RBCs can be there, sir, in ATN also, sir, and glomerular nephritis can be there, sir. So we have to look for the nature of RBCs, sir, like cast or any dysmorphic features are there or not, sir.
Okay. So what is this dysmorphic RBCs?
Sir, like crenated RBCs, when that RBC is basically going through glomerular vessels, if there is inflammation, then there will be, sir, a distortion of RBC structure, sir.
So does the urine microscopy say that I'm distorted, or like what dysmorphic RBC essentially means? You have RBCs of all these shapes, because RBCs will go through the tubules, and tubules will have different osmotic gradients and other things, through which some will be small, some will be big, some will be contracted, some will be cremated. So this is dysmorphic. So is it you find one dysmorphic RBC and you make a diagnosis of dysmorphic RBCs, or how is it?
But more than 5 dysmorphic RBCs, with sir presence of cast, we can call it, sir, glomerular etiology of that
So I
hematurus.
think shortage of time, but it's not 5%. I don't know where you read that. It's 40%. If 40% of your RBCs are dysmorphic, then you call actually dysmorphic RBCs, not small number. So,
Yes.
and they are largely specific for glomerular origin of protein for whatever the disease are like. Then so if there is RBC cast, it moves more in favor of RPGN. If there are only presence of RPCs and there is also presence of WBC with some WBC cast, it can go in favor of tubular interstitial nephritis. Obviously, if it is because of a bacterial infection, then you make a diagnosis of acute pyelonephritis. So that's how it is. Neutrophils, if there is presence of neutrophils and WBC cast, you make a diagnosis of acute pyelonephritis, likely as the cause of interstitial nephritis. So
Raja, Raja,
yeah,
over next maybe 5 minutes, you will have to wrap up, because there is going to be time for Dr. Aman Sharma as well, and I think
yes.
so.
So
I think
I'm
we
coming to
can
that.
move ahead.
Yes. So we will with this diagnosis. So what are the serological tests that you'll do? So we'll stop at exactly another 2-3 minutes. We will stop, sir. What are the main tests? So you told about the hemogram, renal function test, and everything. What would be the other tests that you would look at?
Sir,
Serological tests that you would do.
CRP, ESR, CRP, PR3 ANCA, MPO ANCA, and anti-GM titers, sir. C3, C4
Yes.
also, sir.
Yes. So these are the serological testing that you should do, that would help you, identify the cause of the RPGM.
Yes,
And
Srinath, if you have got slides,
yeah,
can you go with the
you run through
slides?
them.
yes, sir. So this was the systemic examination. Urine dipstick suggested of, sir, 1
Slides. Please move the slides.
Okay, sir.
Okay.
Sir, this is biopsy report, sir.
Biopsy.
Final.
No, I think go to the biopsy report.
Yeah.
You can read it. You can read it.
Light microscopy. So this biopsy comprises of 7 glomeruli, and all glomeruli shows crescents of variable age. 3 are cellular, 3 are fibrocellular, and 1 fibrous, with underlying tuft showing non-proliferative glomerular morphology, with few glomeruli showing intraglomerular sclerosis. There is a rupture of Bowman's capsule, inciting inflammatory reaction in the periglomerular location. There is evidence of moderate acute tubular injury accompanied with early fibrosis and moderate increase in lymphonuclear inflammation. The tubular atrophy is mild, accounting for 10 to 15% of the core. Arteries and arterioles included in the biopsy shows mild fibrointimal thickening and mild arteriosclerosis. Immunofluorescence shows a total of 4 glomeruli. IgG is trace IgM 1 plus, C3 1 to 2 plus, C1q trace fibrinogen 3 plus, and granular deposits along capillary wall. So in view
So,
of
So for the residents, how do you say it is cellular means, so if there is more than 3/4 of the matrix is having cells, so it is cellular. And in somewhere between 10 to 75, then you call it as fibrocellular, and less than 5%, then it is fibrous. So that's how you grade based on the cellularity, you grade the nature of the crescent. And you see they have written rupture of Bowman's capsule. So this is very important. Glomerulitis in native kidneys and glomerulitis in transplant is slightly different. So you should have a rupture to say glomerulitis in a native kidney setting. And presence of any inflammatory cell in the glomeruli is suggestive of glomerulitis in a transplant setting. So this is two important points that comes to my mind. And obviously this is I think this is a crescentic GN because everything is showing crescent. So that's what all of the glomeruli show crescents. So that's how it is. Yes. So there is a lot of activities there. So yes. So if you want to go with the classification, this is crescentic. It's a mixed kind of picture. Yeah. I know it's more than 50% is showing crescent. So I think I would put it as crescent. I don't know why they put it as a mixed kind of picture. So I'm not very clear about that. Yeah.
Yeah, you said chronic kidney disease with pulmonary edema could have been one of the differential diagnoses which Dr. Raja was talking about. And so you said that to identify chronic kidney disease, you have nocturia. And why do people with chronic kidney disease have nocturia?
Sir, because of ADH resistance, sir.
Because of
ADH resistance, sir. Antidiuretic
ADH.
hormone peripheral nephrogenic because of that.
Because of that, you're very sure. What happens in patients of chronic kidney disease? What are the other reasons? This could be one of the reasons, but what are the other reasons which seem to be more?
So
what are the other reasons? In addition to
presence of uremic toxins can lead to hyperosmolarity, and that can cause
that might happen in a very late stage, but not in. This is an early symptom of chronic kidney disease, isn't it?
Decrease in concentrating ability of tubules can be there.
Because, okay, I can accept that. More common than that, which happens in every patient of chronic kidney disease. What happens if 1 million nephrons, 75% of these are dropped over a period of time? They are slowly dropping off. And what happens to the rest of the glomeruli?
Hypertrophy of remaining nephrons.
And?
So hyperfiltration can be there.
Hyperfiltration of this. So every remaining single nephron has to work for the other 75% of the nephrons which may have already been destroyed in the process of chronic kidney disease. So now what happens in these 25% glomeruli? So there's increased filtration. So that's called what? So single nephron glomerular filtration rate
will increase, sir.
Goes up in these. So this is body's compensatory mechanisms which try to maintain the kidney function as well as preserve the solute and the other concentrations in the body. So there is solute diuresis.
Yes, sir.
Isn't it? So there is solute. Per nephron, there is solute. So when solute diuresis happens, what happens? So
any example of solute diuresis? Any example of solute diuresis? Common condition.
Sir, after giving some mannitol and other
all diabetes,
diabetes, diabetes, nocturia nahi hota hai diabetes
all these problems.
So
diabetes is a common.
Because of the solute diuresis that occurs, single nephron loss, and that's what leads to polyuria. And what happens to the osmolality in patients with chronic kidney disease?
Sir, concentrating ability reduced, so osmolality it will get reduced, sir.
No, what happens to the osmolality?
Sir, reduce, sir.
No, reduce means what? It is reduced to 50, or what happens? What happens to these patients in addition? What is isostynuria?
Sir, specific gravity of urine and blood will be equal, sir.
Osmolality and specific gravity is determined. So osmolality and specific gravity gets fixed at 1010, and urine osmolality is also fixed at one time. So when you are making 24 hours urine,
Yes,
what will be usually with the regular kind of water intake, urine volumes in the daytime and nighttime in an isosthenic uric individual?
Sir, in isosthenuria, there will be
so if a patient is passing 2 liters in 24 hours, how much will be in first daytime 12 hours and how much will be at nighttime 12 hours?
Sir, 2/3 in the daytime, sir.
Why? Isosthenuria.
In isosthenuria, there will be increase in
Yeah, but chronic kidney disease, there is isosthenuria. That's
Yes.
exactly what happens. So in chronic kidney disease, there is isosthenuria. The specific gravity gets fixed at 1010. Osmolality is also fixed. You
Sorry
do
to
too much
interrupt,
of
sir. I
changes
think
in that.
I think
we can go to Dr.
yeah, we
Yeah.
can go to Professor Aman Sharma, and then after the discussion of that, we will come
Yes.
back to the case
Yes.
because
Yes.
we have not discussed what treatment or options you have given. Let the theoretical part be there. Professor Aman
Yeah.
Sharma.
Yeah, I know that. I now it is probably visible to me too.
Yes,
I
it's
was
already.
trying to
Yes,
go into the
That's
systems.
fine.
yes,
Perfect.
yes. Yeah.
Perfect.
To everybody, I think I logged in at 6:50. But anyways, let's see what I can do in the next whatever time you've got available. So the basically for the residents, the ANCA-Vasculitis management is borrowed from chemotherapy induction phase and a maintenance phase and the long-term follow-up phase. So you induce with the drug and then you maintain for a period of time. And once you have a maintenance, then there are long-term issues which probably are beyond the domain. Basically, you look for the malignancies, look for other cardiovascular risks and all that. But we'll be concentrating largely on induction and maintenance phase, which is being borrowed from chemotherapy again. And diseases are inherently relapsing. So whenever there is a flare, we go back, especially if there is a major and a renal flare, we go back to reinduction. So we go in cycles. So we induce remission, we maintain it, and if there is a relapse, although relapse rates have come down with the therapies that we have these days. So if he has to listen to me in the beginning and go back home, there is one simple slide that only 2 drugs for cyclophosphamide or rituximab. Whole game is by and large for majority. But how do we choose in between and what should use rituximab or you should use combination of rituximab plus cyclophosphamide? I'll delve deep into that. So if you look at the guidelines, there is a long list of guidelines which have come recently, including the 2021 American College of Rheumatology guidelines, 2022 EULAR guidelines, and then last year the KD goes update and the data-driven Indian Rheumatology Association guidelines we brought out. And this as was shown by the Cyclops trial also, that the risk of infection. These are only conditional recommendations for the use of cyclophosphamide, rituximab over cyclophosphamide. So their IV or oral, that is just hiding behind the fact, and then they went again and said that perhaps these questions they remain, and then these guidelines are basically.
We're not able to hear, or is there a problem with my screen, or is it?
No, I think we're not able to hear him as well.
Yeah. So I was thinking there's a problem with my internet.
You should have used rituximab plus cyclophosphamide. And say rituximab.
So I think there's some network challenge at the location, so it keeps on getting connecting and reconnecting. So
apologies for
Aman,
whatever all is happening beyond control, starting off from
yeah,
the, whatever.
yeah.
Anyways, rituximab has to be
You
preferred
were
where the
actually saying,
fertility.
sorry to interrupt, you were actually saying about the IV and the oral cyclophosphamide. Can you please just quickly summarize that part before you go into this, sir? Like, the part is actually,
Yeah,
there is a
the issue
break in
is
communication.
absolutely, this is very important, and I'll touch on this also in detail. Oral cyclophosphamide actually should never be used. We have a Cyclops trial, which I will probably briefly touch, which was published in 2010, which showed that IV pulse cyclophosphamide is as good as oral with much less side effects. Remember, the hemorrhagic cystitis and the malignancies, most of those side effects are cumulative dose associated. When you use oral cyclophosphamide, you use 2 milligrams per kg body weight. And if you use it in a 60 kg person, you will probably be giving 120 milligrams a day, which means around roughly 3.6 grams a month, which is around more than 18 to 20 grams in 6 months. So, which is a lot of dose of cyclophosphamide. Vis-a-vis IV pulse cyclophosphamide, you will not use actually more than 6 grams of cyclophosphamide. So, IV pulse has to be given, although the KDIGO says that either of these two can be given. And I'll touch upon these very, very important point also in greater details for those who want to know. Rituximab, actually, we know that cyclo causes infertility. So in that subgroup, perhaps the rituximab has to be the drug of choice. And the otherwise, the cyclophosphamide, as per the KDIGO guideline, they say that since there is not much data in advanced renal failure with rituximab, you should use cyclophosphamide in that subgroup also. So this is how the KDIGO says. And, but oral, they say that it probably, if their cost is an important factor, if there is adherence is not an issue, perhaps you use oral cyclophosphamide. And they are saying that Cyclops did show there were some more increase in relapses. But even in the first Cyclops and the long-term follow-up Cyclops showed that mortality was not increased, even though there were minor non-life-threatening relapses with IV pulse cyclophosphamide. So perhaps with all those things in consideration, I would say that IV pulse cyclophosphamide is as good in inducing remission. So when there were so contrasting guidelines, we felt that there was a need for Indian guidelines because of the different socioeconomics and because of the different demographic profile. And we've ourselves published some PGI data which suggests that the advanced renal involvement, at least in the large subgroup of PR3 positive ANCA-Vasculitis, is not as common, like it's 40 to 50% as far as our experience. The same is experienced from Dr. Ashok Kumar in Delhi. It is less as compared to the European cohorts, and our renal outcomes are relatively better, at least in the larger component of PR3 positive ANCA-Vasculitis. So a data-driven exercise was done. We had with Dr. Raja Ramchandran as a nephrologist and Sahajal Duria as a pulmonologist and a patient representative participating in these data-driven guidelines, which are published in around this Autoimmunity Reviews, which is a very prestigious around 10 impact factor journal. The basic recommendations are that you can use either cyclophosphamide or rituximab. There is no, as of now, the IRA guidelines do not suggest combination of cyclophosphamide plus rituximab. And there is also a data-driven recommendation which says that pulse IV cyclophosphamide should be used, and this recommendation is over the daily oral cyclophosphamide. So practically, you should never be using oral cyclophosphamide. We know ever since cyclophosphamide has been introduced, these decadal mortality rates have actually come down, but cyclophosphamide, we are concerned with infertility and malignancy. Raja, this is the study, Cyclops study, which was Christiana de Groot study, which showed that oral and IV cyclophosphamide do as good. There were only some minor increase in non-life-threatening relapses, but mortality rates were the same. So, and the long-term follow-up also confirmed the same. So practically everybody should be actually using IV pulse cyclophosphamide. So this is the long-term data where there was no statistical difference, as I've already alluded to when we discussed. The other important factor which the resident must remember that as the age advances and with the renal failure, there has to be a dose modification of cyclophosphamide if you are using cyclophosphamide. The game changer were the RAVE and the rituximab trial. The RAVE used oral cyclophosphamide, and the rituximab, there was a use of use of IV pulse cyclophosphamide in the advanced renal failure also. But these two trials in the same issue of New England Journal of Medicine, they showed that rituximab now is non-inferior to cyclophosphamide as far as remission induction in ANCA vasculitis is concerned. But remember that RAVE never met the superiority criteria. So if somebody tells you in the naive patients the rituximab is better than cyclophosphamide, actually in this trial, the rituximab did not meet the superiority criteria. And also remember that RAVE excluded severe patients with lung hemorrhage and those with advanced renal failure of creatinine more than 4. Actually, these were the patients which were part of the rituximab trial who had advanced renal failure. Another induction trial was ritaziram trial, which had two phases. One was the induction phase, and then was the maintenance phase. Even in the induction phase, and these were all relapsing patients. Even those who were having relapsing disease, when rituximab was used, you can see that a large group of patients at month 4 did very well with rituximab. Now, coming back to the KDIGO guidelines, and a common question which is asked is whether you should be combining cyclophosphamide with rituximab, especially as a nephrologist, if you come across a patient who has a advanced renal disease with very high creatinine. So, this data has largely come from our UK colleagues, where they have published, Liz Lightstone from Hammersmith. This was the study which used rituximab 1 gram into 2, and cyclophosphamide was used 10 milligram per kg body weight and not 15 milligram, we generally do when we use cyclophosphamide alone, to a maximum dose of 750 milligram. They said there was no this was low cyclophosphamide vasculitis thing, no differences in the relapses or end-stage renal disease or death. But one thing one has to remember, that when you give combination, there is always the most important fear is fear of infections. And we have also burnt our fingers when we tried to use rituximab plus cyclophosphamide, because if you remember in the first year of ANCA vasculitis, and this is from the Mark Little's group in Dublin, where probably the infection rates might be considered to be lesser as compared to our population. Even there, the 40% of deaths in the first year of ANCA vasculitis were actually because of infections. So you have to, and this was a non-restricted group. This is not just a combination of rituximab plus cyclophosphamide. This is either rituximab or cyclophosphamide, or maybe a small subset with combination. But you can see the largest contributor is infection. So if you are considering blindly following one guidelines, you must also keep in mind that what kills these patients many times in the first year is infection and not the disease per se, as per this data. Another very important message that I want to drive home across is that there is conditional recommendation, again data driven, against use of mycophenolate as first line therapy, both either in GPA or MPA. Actually, what people tell you is based upon this study, which was published in ARD in 2019, where they say that time to primary remission and time to first relapse, there was no considerable difference in the total cohort. But actually, there were more relapses in statistically much more relapses in PR3 positive ANCA patients, and the relapse-free survival was also shorter in patients with the MMF group. So it's not actually a very good drug for remission induction. And the other recommendation is, methotrexate also should not be used for remission induction in patients with GPA or MPA. When we come to maintenance, there is a very strong recommendation based upon the data that we have that rituximab, which we use low dose rituximab, 500 milligrams every 6 monthly over azathioprine. We all know this was a cyclophosphamide trial, which was azathioprine was as good as cyclophosphamide, published by David Jane in 2003. But this was a game changer, wherein only 500 milligram of rituximab every 6 months, there was a statistically significant difference in favor of rituximab over azathioprine. Well, David Jane asked the question, based upon what they saw in Cyclops also, that relapse may not mean mortality. So this question was answered by a long-term follow of this Mentorship trial, which in fact showed that there was a mortality benefit in patients, probability of remaining alive, statistically significant difference in favor of rituximab in the Mentorship trial. So even in the retaziram trial, which was in relapsing disease, it was shown that there is a benefit of rituximab over azathioprine. So there is a compelling evidence in favor of using rituximab in remission maintenance. Although in retaziram, the dose which was used for maintenance was 1 gram every 4 monthly, which the David James group has been doing. The other drugs, if you can't use rituximab, which can be used for maintenance, are azathioprine or methotrexate or even leflunomide. I would say just be a bit cautious with methotrexate, because if there is a relapse, which is a renal relapse, then patients on methotrexate might develop, and many of times the creatinine may go up to 2, 2.5 without having any symptoms. So in that subgroup, if you are using weekly methotrexate, the patients might present with life-threatening cytopenia. So probably if you can't use rituximab, my choice would be either azathioprine or leflunomide. Again, as far as a remission induction, mycophenolate should actually not be used for remission maintenance also. This was shown that in the IMPROVE trial, which showed that we have rituximab, which is better than azathioprine, and MMF was inferior even to azathioprine in the IMPROVE trial. So actually, methotrexate, MMF is not a great drug for either induction or maintenance. Now, coming on to very important another question, which is how long do we really treat? Our recommendations say you should treat at least for 48 months. And this is again data-driven. This is Mentorship 3 trial, wherein the patients were doing well on Mentorship 2 were re-randomized on time 6 monthly rituximab infusions. And they showed that scheduled rituximab infusions are better. But this was a sub-selected group which was not relapsing. And even a sub-selected group which did not relapse, there were 10% patients who actually relapsed. We then wrote again after these guidelines that drug-free remission seems to be a reality. And here Louis Gullivan and groups, they actually accepted our notion. And they said that perhaps the maintenance has to be there for at least 4 years or more. And this decision again has to be taken looking at how the way disease has been behaving in a given patient. So once you've decided you are giving rituximab, so do you give rituximab every 6 monthly or schedule on PR3 or on CD19? There was a Mentorship 2 trial which showed that if you based upon PR3 positivity or repopulation of B cells, you probably might end up giving less rituximab. But actually, we saw that when you read in between the lines, and that is what we do. When we did the systematic, with the critical appraisal of this paper, we saw that the relapses were occurring even when the B cells were not populating, and even when the PR3 was not getting positive. And when we looked more critically, we saw that they took a relapse rate of 35%. Arbitrary figure to calculate the sample size, and whereas in Mentorship 1 the minor relapses were 11% and major relapses were only 5%. And if they would have taken this number of 5% and 11%, the sample size for Mentorship 2 would have been very, very big. And then actually, and the follow-up was also a short period of time. Based upon what we wrote, that the Louis Gullivan and French Vasculitis group people, they agreed that actually their study was underpowered to get to that recommendation. And also, if there was a longer follow-up, even then, whatever little significance was there, even with that small sample size, would have become insignificant. That is why, based upon this, you would see Mentorship 2 has not actually made its impact on any of the major guidelines. And that is why, for the residents, I would say that look at literature, you should always do a critical appraisal of all the evidence that is presented to you. The other question which is often asked is, it's a life-threatening disease, should we be using biosimilar rituximab? So I think we looked at our own data, both in remission induction, we don't have time to go into it, but you can look at this paper, and in remission, in relapses, and in remission maintenance. We use only rituximab biosimilar, and it did as well as the innovator drugs. So actually, you can use rituximab biosimilar also with confidence. In relapsing disease, if somebody is relapsing and is especially PR3 positive, then you should always prioritize rituximab over cyclophosphamide. There is enough data. Isolated when we are not very confident in the very beginning and we fear that there might be some infection, we hide behind IVIG. But we give recommendation that IVIG should not be routinely used for inducing remission. Only in the presence of active infection, you might buy some time to use IVIG. It's at best a very weak bridge, but it cannot be a major form of therapy. And the next question, which the nephrologists I'm sure are very important or very interested to know, is when do we use Plex? Again, the jury is still out. Most of the recommendations say, based upon data, that whenever creatinine is more than 5.8, you should use Plex. Our guidelines and ACR and Euler guidelines also recommend against the use in diffuse alveolar hemorrhage. There is some data, or Robert Spira's group also. There is a data from the PaxiVas trial. This is the PaxiVas trial, which showed that it didn't make any difference. And the KDIGO actually says that you can use it in DH, but most of the other recommendations and the data-driven IRA recommendations also say there is no place actually. The other question is which dose of corticosteroid. Actually, this is the PaxiVas rapid taper off regime, which should be there on our desktops. People have also tried giving 0.5 milligrams of steroids also. We are going towards lower and lower doses of steroids, and this is what everybody must remember. The other question, the other very important message is always do serum IgG levels, because if it is less than 3, then it is likely that there might be severe infections. So you might give a maintenance dose of IVIG and then give rituximab if it is given. So to conclude, this is the summary slide. Actually, for active GPA or MPA, we should use steroids and rituximab or cyclophosphamide, and use rituximab for maintenance, which is to be chosen over azathioprine. And these are the comparisons. If somebody wants to take a snapshot, the only difference, if you see the ACR says only use rituximab, EULAR says rituximab over cyclophosphamide in a major life-threatening disease, KDIGO says a combination or only cyclophosphamide, whereas IRA guidelines say rituximab or IV pulse cyclophosphamide. Plex actually advanced renal failure as per the EULAR and IRA guidelines, and also for DAH as per the KDIGO. As far as maintenance is concerned, by and large, there is consensus in large majority that rituximab should be used as the drug. Avacopan, we haven't included in our guidelines because it's not available, but it's a drug which can be used as a steroid sparing agent. It's prohibitively expensive to bring it, and it can at best replace corticosteroids. So with this, I wish to conclude that I would use either IV pulse cyclophosphamide or rituximab for remission reduction. And rituximab has to be preferred in a young patient or with relapsing disease. And rituximab will be the agent of choice for remission maintenance. And I would use a low dose or rapid taper corticosteroid regime. With this, I'll probably wish to stop and would be happy to answer any questions.
Thank you very much, Professor Aman. Wonderful. And what I basically feel, where you are differing with KDIGO guidelines, which you have emphasized, one, you say that when KDIGO says oral or IV are almost similar, you are emphasizing that logically, because of the very high dose being used in the oral, it is preferable to use IV cyclophosphamide, whereas where you are giving possibly 5 to 6 grams versus 12, 13 grams. Second, you mentioned you deplored the use of combination of cyclophosphamide and rituximab, whereas KDIGO does mention that if it is severe organ-threatening disease, both can be combined. Third, again, you mentioned that rituximab as a maintenance therapy is equally good and rather better than azathioprine, and preferred drug will be rituximab. And fourth, possibly good thing you told, that biosimilar rituximab is almost equivalent to the original molecule. I think with the, can we switch off the slides now? Then we have discussion.
I stopped sharing, sir.
Stop sharing.
The control people. Control people will have to do the needful.
Yeah, I think I'll ask Raja then how did you go in this particular case?
Let's give Srinath the privilege of answering these questions because he's got the
Srinath, you went,
details.
as you mentioned, you went by rituximab and then
Yeah,
and
plasma
later
exchange and
on,
then rituximab.
Started on sir plasma exchange and followed by sir 1 gram MPS for 3 days and followed by 1 mkd steroid Pegzy was as per Pegzy was followed by tapering and rituximab has been started sir for induction.
okay.
The other
One
question that we, what kind of rituximab
Raja,
did you
I'll
use?
ask one question which is very often asked by people.
Uh-huh.
Sometimes you get a biopsy report. Let's say there are 10 glomeruli, 5 are fibrous, 3 are fibrous, 7 are fibrous, 2 are fibrocellular, 1 is cellular. Will you treat it aggressively or not?
I think I think it's a difficult question to answer, sir, because you're not going to use evidence to answer. It's more of what experience do you have. So you'll take into account, if there is any normal glomeruli left. So if there is some normal glomeruli left, I think that will be one of the strongest feature that you should consider while giving, good immunosuppressive therapy. Again,
That's
it's
what
not
I
only the
felt.
it's not only the glomerular compartment that is important, but it's also the tubulointerstitial compartment. Suppose you have 80% IFTA is there, that means that is a burnt out disease. So if there is no that much of IFTA, that much means maybe less than 50%, I think I would give my shot and give the patient immunosuppressive therapy. But if having said that, if everything is fibrous crescent, I would hold my horses and only treat the extrarenal manifestation aggressively.
I fully agree. I think even if
Another
there are one,
point.
We have
if
Dr.
there is
Kashi.
no IFTA,
Kashi sir is
okay, we
saying
will
something.
go to his expert opinion that
Okay,
if there is
okay.
no IFTA, and even if one or cellular percent is there, I think there is a point going ahead for
Yeah.
aggressive treatment, salvage.
Yeah.
Professor Kashi,
Can I
sir.
say
One
one
other
thing on
point
this
that you
point?
need to
Yeah,
consider.
please.
Yeah,
Dr.
the
Kher and
question.
then
Yeah,
finally Professor
yeah,
Kashi.
yeah. The
Yeah.
point, what you're saying
Yeah,
is
one-
that the pathology, as was seen in this patient on the histology, also you see a variegated.
Yeah.
It's not like an anti-GBM disease that all the
Yes.
glomeruli will be in the same stage of disease.
Yes.
So this is a disease which is associated with maybe subclinical remissions and relapses, which clinically may not be manifest as such. But when you look at the biopsy, there will be some uh, pieces of the kidney which may be good. There will be other pieces which will not be good. So because of this variegated, it has been recommended by most people who have treated vasculitis enough that if out of the most advanced glomerular disease, if this is vasculitis, then probably go ahead and treat these patients, and you might be surprised to see significant improvement in clinical states.
One other point that you need to consider in the case of a crescentic glomerulonephritis is the status of the endocapillary area. If there is proliferation of the endocapillary area, the prognosis is better. So you can prognosticate a case of a crescentic glomerulonephritis by looking at the endocapillary area, as well as, of course, as Raja said, the IFTA. So if you have endocapillary proliferation, the chances are that the patient has got recovery chances. With a fibrocellular crescent, you go ahead and treat it, whether it is ANCA related or anti-GBM or whatever.
May I say something?
Dr. Aman, please, sir.
Yes, sir, actually, we will have to look at from two perspectives. One, if it is the first presentation with this kind of a kidney biopsy, we have to remember that this is a systemic disease and it would be grumbling somewhere else also. Only less than 10 to 50, it's just a matter of time that it manifests either here or somewhere else. So if it is the first time presentation like this, I think we should go ahead and treat with whatever is salvageable. Say, for example, even if somebody was dialysis dependent in the beginning and becomes dialysis independent, and creatinine, say, for example, comes down from 8 or 9 or 10 to 2 or 2.5, we see patients actually stay there for quite some time. Actually, you might either be halting progress towards renal transplant, or you might be actually, in some of them, mitigating renal transplant. That's point number one. And point number two, besides the kidney, this disease is generally
Renal.
actually hotting up other areas also. The difficulty arises when you have adequately treated it and you patient come with this kind of a kidney manifestation, then you go for reinduction or not. Then you will have adequately treated still second time around. This is the kind of presentation. Then you probably will. Then the way you treat probably might be slightly different. But in the beginning, whatever you can do to salvage, I think that's what Dr. Vambri also used to say. Probably throw the book at the
Yes.
patient and then see what happens.
Yes. Yes.
Right. There are some questions in the chat box. When to start ASA after induction with cyclo-oblique rituximab?
Dr.
Do I
Aman,
reply?
if you have a
Yes.
patient who cannot afford, then as you said, ASA would be the best choice. So when would you consider a patient to be in remission?
Nowadays the cost of rituximab is
Yes,
7,000
it's come
rupees or
down.
6,000
Yes.
6,000
Yeah.
rupees for 6 months, 1,000 rupees a month. So practically it will be almost same
Yeah.
with
Yes,
as
Vamri.
as a thiopurine. It's just a matter of just convincing the
Yes.
patient.
Yes.
Yes.
We actually we somehow, even if somebody is not able to afford, get it from charity or somewhere. We always, because there is a mortality benefit and the cost has come down substantially. But even if in some patients, if there is grumbling disease, when do we start ASA? Immediately after. Because
Immediately afterwards. Yeah.
Yeah.
and azathioprine is going to take time to start to kick in. It will take
Yeah.
few months actually. So start immediately, but start with a low dose. Start with a low dose of 25 milligrams. And one thing which I want to tell residents, many residents are under the impression that azathioprine does not require dose modification in the presence of renal failure, which actually is not true. In the
Yeah.
presence of
It
advanced
does.
renal
Yes.
failure, even azathioprine requires dose modification. So
Yes.
these are the 2 points which one should remember.
Yeah.
And when we used azathioprine, please keep in mind that get a TPMT polymorphism. It's important. There have been issues because of that, and with respect
TPMT
to
and Raja and
TPMT
NUDT. And
NUDT,
TPMT
yes,
and actually
NUDT,
India NUDT
NUDT
is
is
more
more
common than
important.
more
Yes,
common than TPMT.
yes.
Raja, in PGI, just two comments for the audience. The question: are you using any combination of rituximab, cyclo, and what criteria you are adopting for plasma exchange?
So, to be
PGI,
honest, we are not using a combination of cyclophosphamide and rituximab
but
for
that is why.
managing. So that's very clear
But
about
that is
that,
why.
sir.
Whatever the
And
severe disease, whatever may be, you are
so,
using one of them.
So, with respect to the plasma exchanges, isn't very clear, sir. So, we obviously we have a discussion with the patient telling that there is a clear-cut benefit with respect to the kidneys. But yes, it comes with an acceptable risk of infections, which we will have to factor. And majority of our patients are not, very few of them are able to understand the gravity of what we speak. So obviously, they obviously give it to us like, please take decision on our behalf. So in those situations, yes, we do consider plasma like exchange. Like this patient, we did consider plasma exchange because he had DH and also, the creatinine was over 5.5. So that was the reason. So yes, if severe disease, acute, we do consider plasma exchange if it is more than 5.8. Risk of infections, we do explain to patients. But that is what the systematic review also suggests. Here is a benefit, but it comes with infection risk that you need to tell to your patient.
Professor Kasi sir, words of wisdom.
Yeah. I think the presentation was by and large good. But there are certain things that I just want noted down about the presentation. See, the fluency, the body language, and the continuity are important. When you are speaking, it may be mannerism, but saying ooh, like that in between takes away the continuity. And then the second thing is, probably I may feel that it is my obsession. But when you say no history of, etc., for every symptom, no history of anemia, no history of alopecia, no history of facial rash, etc., I think you say the no history of once and then continue all the negative points that you want to mention the history. This is one trend that has not been trained during your MD time. And so you just, it comes as a music, which is not really attractive. Then the general physical examination has to be systematic. You start from head to foot, or you say about anemia, jaundice, cyanosis, clubbing, lymphadenopathy, etc., etc. It has to be systematic. You have skipped the general examination in your presentation, even if there is nothing. In fact, you mentioned about the ulcer and the angle of the mouth. You attributed it only to the ANCA-related condition, but there are so many other conditions. And angle of the mouth ulcers is more characteristic of a vitamin B2 deficiency. So that is something that you should have considered and mentioned, that angle of the mouth, because the vitamin deficiency is so common in our country. So you need to think about common things also. Urine examination is part of general examination. Our professor, Dr. Chuk, used to insist on urine examination by the clinician himself. And even today, I do the urine examination in selected cases, not every case though. So at the end of the case presentation, the first thing that you must mention is not ANCA result or anti-GBM antibody result, but you must mention about the proteinuria and hematuria, which is very relevant in this case. Once you have given all this, then you need to have a syndromic diagnosis, as Dr. Raja mentioned, and then discuss various possibilities. Straight away, you have discussed only the ANCA-related conditions. As we discussed in the differential diagnosis, tuberculosis is there. There are other conditions causing RPRF. So they have to be mentioned, and then you exclude them. That in view of this particular symptom, we are excluding the, sarcoid, etc., etc. I want you to explain to me, just to say, the pathogenesis of ANCA, how ANCA comes and how ANCA causes vasculitis. Can you do it? As if you imagine that I am an undergraduate student trying to understand ANCA, and I want you to explain to me the steps in the pathogenesis of ANCA-related vasculitis. Not in great detail, but in very simple terms. Try.
Sir, any trigger like infection, which leads to basically priming of neutrophils, which leads to the PR3 and MPO come to the surface of that neutrophil. There will be formation of antibodies against that, and that antibody formation leads to activation of neutrophils, leading to degranulation and activation of reactive oxygen species, which further leads to damage to the involved vessel and tissues where the neutrophils are there, and formation of granulomas can be there because of MPO, and there can also be formation activation of alternate complement pathway because of activation of C5A, which further leads to auto amplification of C5A and C5A receptor, which further activates neutrophil and C5A, leading to alternative pathway activation, and further leading to formation of granuloma and inflammation. Sir.
What is neutrophil extracellular trap?
Sir, there is a degranulation of neutrophils, leading to there is a formation of netosis will occur, sir, because of there will be extracellular intracellular contents of neutrophil get degranulated, and there is a formation of reactive oxygen species, leading to formation of netosis, sir.
Okay. Now, what are the factors that stimulate the degranulation of neutrophils?
Sir, C5A anaphylatoxins can stimulate degranulation, sir.
C5A doesn't cause degranulation. Degranulation and expression of the PR3 and
sir, any
on the neutrophil surface.
Sir, any trigger?
Yeah, what are the triggers?
Sir, infection can be the trigger, sir.
Infection is a trigger, great.
Sir, any hydrocarbon, any smoke particle can be trigger for activation of neutrophils, sir.
Okay, these are the points that I just wanted, because you need to understand the pathogenesis clearly in such a way that you should be able to explain to a person who just has got a basic idea.
Thank you very much, sir.
That must be something like a story. Once upon a time, there was a king, like that it must be a story starting from the beginning. So you start off saying that the polymorphin nucleus, neutrophils have got granules. They are acidophilic granules. And during a certain stressful situation, the granules are expressed on the surface of the cell. They are the PR3 and the myeloperoxidase. And then autoantibodies are formed elsewhere. They come and tag on to this. And then when the antigen antibody comes, it starts activating the complement pathway. And then the complement mediated damage comes. And these cells attach to the endothelial cells and then burrow through the endothelial cells into the endothelial coat. And then start proliferating there because of the chemotactic factor and as well as the, all the other factors, anaphylatoxin, all these mediators of complement pathway. So that is the way you need to explain the pathogenesis of.
Thank you, Kasi sir. Thank you very much. I think fantastic presentations. I'll hand over to Professor Kher to give the final word. But from my side, I thank Dr. Raja and Professor Aman profusely. I mean, masterly clinical case taking and presentation. There were some glitches because of slide presentation and all, which took us 15-20 minutes. Otherwise, we would have further hearty discussion. There were a lot of questions in the chat box. I think Dr. Raja and Aman have been quietly answering. Dr. Kasi also have been answering that. Professor Kher, sir.
Yeah, I think it was extremely a great session, and I think especially Raja and Aman did very well. I think for the first time you hear an Indian guideline as well, and which is, in my opinion, seems to be superior to the KDIGO guidelines. At least from Indian perspective, I feel that the confusions which are left in, and I think the Indian guidelines must be, I think Aman and the group there must be complimented for giving very clear-cut kind of guidelines, and I think that's something very good. And I hope that these guidelines are also circulated to the Indian Society of Nephrology, and I think we should, as a members, it would be good to give it to for people to sort of have, because it removes a lot of confusion as regards the management of these patients, and I feel it's good. And I think Shrinath did very well to present this case, and Raja, as usual, has always been exceptional, and Dr. Kasi is a legend. And I think with all this, and I think let's thank Steadfast for this first initiation. My suggestion would be to have as an improvement, so that we avoid these glitches, that for speakers and for the presenters and the 4 or 5 people who are there, we should have a separate link, because then you will be able to use co-host and other things. When you have a larger group, then it may not be possible. So I'm a non-technical person on this, but I probably feel that because this was too long a glitch, and I feel that wastes a lot of time. So I think we will improve next time.
Definitely.
Sorry for that. And I think thank you very much from my side. Good night, and thank you for participating. I saw that about 135 pages.
Yes, sir, 135.
135.
These are only on Zoom, sir.
Zoom, yeah. There will be a YouTube. These are all recorded, and
than 200 people.
Yes. So thank you very much. Thank you. General Verma is, as usual, effusive and eloquent. And General Saab has earned a drink now, and I hope we should let him have it.
I think we must tell the crowd that the next session is a fortnight later.
Yeah,
and that
20. I think 26th or so.
26.
26
June.
26 June.
Thank you very much.
Okay. Thank you. Thank you very much.
Good night. Thank you very much.
Good night.
Thank you very much, sir. And we'll make sure next time. Thank you, sir.
Okay, Shri, all the best.
Bye-bye. Alan sir has just appeared now. Even this is on the. You must be listening, and thank you so much.
No problem.